We've looked at joints already at several points throughout this unit, but to define a joint, it is a union of two or more bones. Another term for it is an articulation. We talked about articulation when we talked about the type of cartilage at the end of a long bone. We said it was articular cartilage covering the end of the long bone, and that articular was referring to that cartilage was being found at a joint, the connection of that long bone to another bone. When we look at the skeleton overall, there's many joints that you find throughout the body. Oftentimes, the names of those joints are made up of the two names of the bones that are connected to each other. For example, the temporomandibular joint is a joint between the temporal bone and the mandible. The sternoclavicular and the sternomanubrial joints are joints between the sternum and the clavicle, or the sternum and the manubrium. The glenohumeral joint is a joint between the glenoid cavity of the scapula and then the humerus bone. The humeral ulnar joint is between the humerus and the ulna bone. And then we could just list a whole bunch of other joints here, but you'll notice that they're all made up of the bones that are involved in that joint. But let's describe the three categories of joints. The first are fibrous joints. These joints are immovable, and they include the sutures that we talked about earlier found between the cranial bones in the skull. We have cartilaginous joints, which are slightly movable, and we've seen those earlier when we talk about the intervertebral discs. We mentioned that the joints between the bones, the vertebrae, are slightly movable because the intervertebral discs allow for a slight movement of the vertebrae up against each other. And then synovial joints are freely movable joints, joints that we're more used to, like the knee, the hip, the shoulder, etc. If we were to zoom in on the knee joint, we'd be able to use it to describe the structure and function of a synovial joint. As we just mentioned, these are the type of freely movable joints that we have in our body, and the knee is an ideal example of that. To get our bearings in terms of the bones here, remember that the femur is connected to the tibia below it, and then at the front of that joint is the patella, the kneecap. As we were just discussing, the surface of those long bones is covered by articular cartilage. As we've mentioned previously, this is a nice smooth cartilage that covers the opposing bone surfaces and gives some cushioning as the bones push on each other. We then have the capsule. This is a double-layered capsule. The external layer is a tough fibrous capsule, and then the internal layer makes up the synovial membrane that we'll talk about here in a moment. We have the lateral meniscus that helps to keep the femur stable on top of the tibia. The synovial membrane that we were just discussing as the inner lining of the capsule covers all of the joint surfaces except those covered via the hyaline cartilage, the articular cartilage. The synovial membrane then releases synovial fluid. Synovial fluid is a slippery fluid that fills out all the free spaces within the joint cavity, as is shown here. On top of decreasing the friction, allowing the articular cartilage to glide smoothly over each other, it nourishes the cartilage and provides nutrients to it. On top of that, at times there might be phagocytic cells that rid that joint then of debris that might get into the synovial fluid as the joint is producing movement. Another portion of a joint that we should discuss is the bursa. To remove some of these labels here and point them out, here we have a couple of bursae of the knee. They're synovial membrane sacs located between the skin and bony prominences. They're common in sites where ligaments, muscles, skin, and tendons lie over and rub against bone. They act to prevent friction on adjacent structures during joint activity so that we don't have damage, let's say, to another bone that is being pushed up against from another tendon. Now that we've taken a closer look at a synovial joint, let's describe the movements permitted by them. The first movement that we'll look at here is flexion. Flexion is the bending of a joint that causes a decrease of the angle at the joint. When your arm is straight down to the side, there's a 180-degree angle at that joint. When you lift it up like this person is here, then we have a 90-degree angle. We've decreased that angle, thus we've flexed the elbow joint. If we were to do the opposite, this would be extension, where we've increased the angle at that joint. Here is extension and flexion of the knee. We bend the knee, causing flexion. We extend the leg, causing extension at the knee. Here we have flexion and extension of the wrist. But our wrist is extended when our hand is flat and continuous with our forearm. At the top of the image here, you can see the person bending their wrist or their hand backwards. This would be considered hyperextension, because to go from the flexion position, we would extend back to in line with our forearm and then hyperextend. We can do this with our neck as well. If we put our chin down to our chest, we're flexing our neck. If we put our head back up to straight level, we're extending our neck. If we were to look up, we would be hyperextending our neck. Another movement would be circumduction. Circumduction is a rotational movement of a limb as though drawing a cone. In this case, it looks like the individual's arm is straight out, but even if you had your arm at a bit of an angle, but then you would turn it in a circle out to the side of you, this would be circumduction. Another motion would be rotation. So in this case, the person is rotating their head to the right, now to the left. Another term for this rotation is sometimes called pivoting. But this is a rotational movement where you're pivoting around a particular axis. Your forearm can also be rotated. So here's another image showing the difference between these two. So on the left side, this person's right arm is being rotated. He's not moving his shoulder, but he's rotating his forearm and his hand. On the right side, or his left arm, is undergoing circumduction because he is moving at the shoulder and producing a cone-like structure if we were to continuously follow his arm there, and this is circumduction. Another pair of movements that we have are supination and pronation. Supination in the hand here is when the palm is face up. Pronation is when the palm is face down. To have a patient lying prone means to have them on a bed lying face down. To have the patient lying supine is to have them lying face up on the bed. Another set of movements are abduction. This person moves their hand directly out to the side and then above their head. They have abducted their arm. Abduction is referring to the movement of a limb away from the midline of the body. The opposite to abduction is adduction, moving towards the midline. When we look at the leg here, we can have abduction, moving your leg out to the side, and then adduction, moving it back towards the midline. A couple of other movements include dorsiflexion and plantar flexion. If you were to move your foot such that you pointed your toes upwards, this is dorsiflexion. Plantar flexion is to point your toes downwards by flexing your ankle. Eversion and inversion. To try to face the bottom of your foot inwards towards your midline is inversion. To try to turn it such that the bottom of your foot is pointed outwards would be eversion. Protraction and retraction. In this case, the image is showing the entire head being protracted, brought forward, and then retracted, brought back. And then elevation and depression. Elevation is lifting upwards, as the person is doing with their shoulders here, and then depression, moving them downwards. Now that we've looked at the movements permitted by the synovial joints, let's look at the various structures of synovial joints, the movements permitted, and then we'll focus in on the ball and socket and hinge joints. Here's the hinge joint. The hinge joint is a convex surface of one bone that fits into the concave surface of another. It allows for movement in one plane only, and examples of it include the elbow, the knee, and the joints of the phalanges. The ball and socket joint is a bone with a ball-shaped head, and it articulates with a cup-shaped socket. We find this type of joint, as is shown here, in the shoulder, but the hip is also a ball and socket joint. There are other types of joints here. Pivot joints, as we saw in the atlas and the axis. There's rotation allowed through this type of joint. There's a saddle joint. This type of joint is found between the metacarpal of our thumb and our carpals. Gliding joints. This is the type of joint that you find between the processes of two vertebrae. And then condyloid or ellipsoidal joints are similar to the ball and socket, but instead of being a round ball at the end of a bone, the joint is a little bit more elliptical, hence the name ellipsoidal that is sometimes used. You find this joint between the carpals of your wrist and your radius. So we mentioned these two types of joints specifically already. The hinge, where you have the convex surface of one bone fitting into the concave surface of another and allowing for movement in only one plane. And the ball and socket, a bone with a ball-shaped head articulating within a cup-shaped socket of another bone. But let's take the time then to look at this ball and socket joint and specifically identifying the structures which articulate to form the hip and the shoulder joints. Let's start with the shoulder. If we were to zoom in here, here is the shoulder. It is an articulation between the scapula and the humerus. To look at the scapula specifically without the humerus in there, this is the scapula. We have the costal surface of the scapula. Costal referring to the rib cage. This is the surface of the scapula that is up against the rib cage, because in the image on the left, you can see that the scapula is behind the rib cage and that costal surface would be up against those ribs. A few other things to point out about the scapula are these borders. We have the superior border on the top, the medial border in the middle on the vertebral side of the scapula, and then the lateral border on the axillary side of the scapula. At the top we have an angle, the superior angle, and then at the bottom the inferior angle. And here we have the glenoid cavity. This is the cavity where the head of the humerus actually fits into it. You can see the gray here is the articular cartilage that's over the surface of that cavity and will be the articular cartilage for that joint between the humerus and the scapula. We have this acromion process and this coracoid process, two processes that are sticking off of the scapula. These are attachment places for muscles. If we move that off to the side, we can look at a posterior view of the scapula. Almost everything here is labeled the same, except for that we can see as you move down from the acromion process, there is the spine of the scapula. And then because we're looking at the posterior side of the scapula, we have the posterior surface. Looking from a lateral view of the scapula, we can see how the coracoid process, acromion process, and then the glenoid cavity are related to each other in terms of space. We can also see the curvature of the scapula in the sense of it's up against the rib cage, which is not just flat, and so that curvature is so that it can move easily up against the rib cage. Bringing this picture back to the middle, we can add the humerus in again, as well as the clavicle. So here we have the shoulder joint overall. We have the glenohumeral joint that we mentioned earlier in terms of naming joints, the connection between the glenoid cavity and the humerus. All of this together, the acromion process, the glenohumeral joint, makes up the shoulder joint. Moving that off to the side, if we were to include the rib cage in there as well, we can again see how all those bones are connected, forming the overall shoulder joint. We've already looked at the pelvis previously and mentioned the hip. Move that pelvis that we looked at already off to the side. Here is another image of a lateral view of the pelvis. We have the acetabulum, which is curved as you can see here, and then here we have the femur and the head of the femur specifically that would then fit within that acetabulum. Here's the neck of the femur just below the head. And then we have the greater trochanter and lesser trochanter. These are areas where tendons of muscles would attach to the femur. The lower part of the femur is where we form the knee joint, which is the connection down to the tibia that is below the femur. Before we get to that, let's look at the various portions of the lower part of the femur here. Here we have the lateral and medial condyle of the femur. The lateral and medial condyles being the wider surfaces at the bottom of the femur, where ultimately they will attach to the tibia. We have the lateral epicondyle and medial epicondyle. Epi meaning above, and so these are on the lateral and medial side of the femur. These areas here that are above the condyle that again act as attachment places for muscles and tendons and ligaments. Here we have at the front the patellar surface. This is where the patella will be up against the femur. Here we have the right tibia and fibula, the bones of the lower leg that would attach to the bottom of the femur here. Here is the fibula and here is the tibia. We have the head of the fibula that then attaches to the tibia, and we have the tibial tuberosity, a roughened portion of the tibia where tendons coming down from the quadriceps, the muscle of the front of the leg, connect. And then we have the lateral and medial condyle of the tibia. These lateral and medial condyles of the tibia are where the lateral and medial condyle of the femur fit. So ultimately, we're talking about this joint here, the knee. We want to describe it, and we kind of already have, but we want to go a little bit more in depth than we discussed earlier. So here is the knee joint. To get our bearings, we have the femur at the top, we have the fibula on the left side, the tibia on the right side of the lower leg. Then on the femur, we have the lateral condyle and the medial condyle. Here we have the patella. So you can see that the patellar ligament runs from the patella down to the tibial tuberosity that we mentioned earlier. We have the quadriceps tendon here that runs from the patella up to the quadriceps, the muscle of the anterior leg. Here we have the lateral meniscus and the medial meniscus. We discussed the meniscus earlier when we looked at the synovial joint, but here we have two menisci, the lateral side and the medial side. They help to deepen the knee joint. They prevent side-to-side rocking of the femur on the tibia. The menisci are only attached by their outer margins. They're frequently torn and injured because as shock is absorbed, it's transmitted to the knee and then can damage these menisci. Here at the front of the knee, we have the transverse ligament. Transverse because it runs in the transverse plane. We have the anterior cruciate ligament. Cruciate is referring to cross. So here we have the anterior cruciate ligament, and then here we have the posterior cruciate ligament, and the two cross each other and they connect the femur to the tibia. They help to prevent anterior-posterior displacement of the joint surfaces. Then we have the collateral ligaments. Here the fibular collateral ligament, and here the tibial collateral ligament. They're lateral ligaments because they're on the lateral side of the knee joint. And there's fibular and tibial because that is representing the bones that they're joining to the femur. So these are all the connective tissues holding the knee together. But we also want to remember that we have bursae. Bursae are those synovial membrane sacs that we mentioned earlier, decreasing the friction between, let's say, ligaments and bone or tendons and bone. So you can see here we have a number of bursa that are preventing friction damage to bone. The suprapatellar bursa means above the patella, and it is making it so that the tendon of the quadricep is not damaging the femur. The deep infrapatellar bursa is below the patella, and it is helping so that the patellar ligament does not cause damage to the tibia. And then the subcutaneous prepatellar bursa means it's below the skin and in front of the patella, is helping to provide some cushioning so that we don't have direct damage to the patella if, let's say, we were to be hit by something directly on the kneecap. And then what we can do here is layer a little bit of the muscles here over top to see how the kneecap is held on to the knee from an anterior view. At the top here you can see the quadricep muscles, and then at the bottom of those muscles the tendons come down and attach to the patella. And then inferior to the patella, we have the patellar ligament that runs down and connects to the tibial tuberosity of the tibia. Altogether, this is the knee. And we've talked about not just ligaments and menisci, but specific ones within the knee joint. Because overall, the knee is a complex joint, but it's one that gives us all of the different components that you would ultimately find in a synovial joint.